Carla Black. I am the Emergency Preparedness Coordinator at the Health Department in Kent County. A lot of you know me from various functions throughout your time in emergency management and first responders and other things associated with the region. So go ahead, forward, Luke. But like a lot of you might not know that like my background isn't all emergency preparedness all the time. Actually, I have a PhD in molecular virology. You don't really want to know about the trajectory of how I got here, but I was a virologist in another life. I used to work on yellow fever, which that's what that molecule is on your left-hand side. And I actually put some of my pretty pictures that I actually made back in the lab because normally when I do presentations for the Region 6 Healthcare Coalition, like everything's all doom and gloom and terrible, and for once I actually get to put up some pretty pictures. And so those are actually some cells infected with yellow fever. Um, so like living in an RNA world with viruses and everything like that, this is very familiar with me. But honestly, like I'm honestly so geeked about this vaccine. It's so exciting because this is the first time that we're going to have what we consider an mRNA vaccine. I'm going to tell you a little bit more about what that looks like. But I know that there's a lot of concern of talking about, oh my gosh, this went really fast, and can we trust something that moved this fast? And I just want to kind of give you like some scientific perspective from somebody who's worked in science for quite a while. Usually, as we are, sometimes you get in those silos and there's a lot of competitiveness of like who's going to make that discovery next, and so there's a lot of like back and forth and competitiveness going across labs. But when you have a global pandemic, this is when people come together, and actually they're a lot like us in that money keeps going down, 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 and so with less money you have less research and less answers. And in this case, all the money is flowing, and so that makes things a lot easier to work collaboratively and get money and be able to make huge strides forward because you have like the best brains in the world working on this. And so this is actually what happens when science has money and is able to come together over a common cause. Next slide. So I'm going to be kind of giving you like a really broad overview of biology right now, so you can kind of understand why this vaccine, both the Pfizer vaccine and the Moderna vaccine, are actually really neat, and it's not really anything that you should be too concerned about in terms of like how it works biologically. So we're going to start off with Biology 101 because I know it's been even almost 11 years since I finished my PhD, and those general science classes were really long time ago. So we're going to go over just some basic 101 of biology to make sense of why this vaccine is really cool and how it's really not really all that out there. So the first molecule is DNA. It's the blueprint of you. It has basically all the little instructions of you. And so it's a double-stranded helix. You've probably heard, the helix of life or other sort of comments like that. But it has all the instructions. Next click. And so within you, you have 23 pairs of what we call chromosomes. So each one of these chromosomes is a tightly wound up piece of DNA. And within each of those pieces of DNA, it has all these little instructions of what makes you you and how all your cells need to function. It has like all the blueprints. Next. And so in terms of like you have all this information all the time within you, you have to have a way to kind of parse out what you actually need now. And so we have this thing called RNA, and I'm calling it the messenger because there is a thing called messenger RNA. That's the type of vaccine that we're using for Pfizer and Moderna. And so basically, next slide, or next. RNA is a single-stranded RNA molecule. So it's very similar to DNA, but DNA has two strands, and it's made up of a backbone, sugars, and some bases, whereas RNA has sugars and bases and a backbone, but it's only one strand, and there's some slight differences in the bases. Next. But the RNA is made from that DNA. And so basically you're just kind of finding like these little messages along your DNA saying, okay, this is what I need right now for my cells to function, or to have blue eyes or whatever you need. Next. So then our third molecule that's like super important are proteins. And proteins are the doers within your cells and within you. And so the proteins are basically your building blocks that are within your skin cells. I mean, like protein is everywhere. They are like the functionality of everything. And so they're very different in how they looked. I mean, so DNA and RNA look kind of similar. One has two strands, one has one, but they're kind of made up of the similar thing. But protein, go ahead. One more time. There you go. Has amino acids, and so that's very different. So if you're looking at this molecule, this is actually one of the molecules I used to work on. This is a yellow fever protein, and so you can see that there's all these like curlicues, we call it alpha helices, that um, that basically make up this protein, and proteins are how they're made, like their structure really dictates their function. And so you can see just by looking at these three molecules that proteins are really different. And go ahead and click again. So this is another type of a protein, so you can see that there's a lot more of those helices that are in there. So those are just kind of like the building blocks I'm going to go with for our talk today on my side. Go ahead. So we have this thing called the central dogma of biology. So we talked about what DNA is. It's the blueprint of you. Go ahead, hit. And so the DNA, the RNA is made from the DNA. Hit again. And this process is called transcription, because basically we're just writing the message down again, except in a slightly different way, because again, we don't want to use all of our messages all at once, because we'd really be kind of a hot mess if everything was transcribed at once, because um, you have certain functions that are different when you're younger versus older. So I'm not going to get heavy into the science. This is just going to be really broad, but we want to make sure that we have the right messages at the right time. And so that's what that RNA is for. And then that RNA then gets, hit again, translated. So we call it translation into protein. And in this case, we're changing the language, because we're moving from the structure of RNA to like a completely new thing with amino acids and proteins. And go ahead. And so kind of one of the major rumors that I hear about the vaccine is like, oh my gosh, the RNA is going to get integrated into my DNA. No, go ahead, hit. Because RNA and DNA aren't the same molecule. They don't really integrate one very well, just because they're very different molecules. So that doesn't really happen. There are retroviruses such as HIV that have a whole different process for how something like that could work, but this is not the situation with coronavirus, because they don't have this type of situation. Go ahead. So another big part of all of this is the cells. So we talked about molecules, but how does this actually work in all your cells? So obviously, like I don't draw very well, but this is my version of a cell, and that's okay. But there's a lot more pieces of a cell than just this, but I just made this to be very simple, straightforward. So really the places that we're looking at in this cell is the nucleus and the cytoplasm. Go ahead and hit again. So in your nucleus, that's where your DNA resides. It's not going anywhere else. It's not hanging out really in the cytoplasm or anything like that. That's the home of the DNA. Go ahead. And when we have the DNA in the nucleus, then that's where the RNA is made. So that's where it's all sitting. But for the RNA really to be active, we need it to get outside of that nucleus and go into the larger space known as the cytoplasm. And so in the cytoplasm, there's lots of different proteins in there that recognize the RNA and then go ahead and make protein. So, hey, look, we're going through like molecular biology 101 in like 5 minutes. Pretty amazing. Go ahead. And so, as you saw, the RNA disappeared. So the RNA messages, like you don't just have like one RNA that's made and then it just stays in your cells forever. They get degraded. They're not the most stable of molecules. Because again, you don't want to have a message from when you're like 3 years old now still in your body as a 4-year-old. That doesn't really make a lot of sense, because we're continuously recycling molecules in our cells. So especially with like RNAs, usually RNA typically is stable for like hours to a couple days depending on the RNA. So they don't just hang out for the rest of your life. Go ahead. So now we're going to talk a little bit about coronaviruses. So now that we have like kind of our general biology 101, behind us, now we're going to talk a little bit about viruses, which are a little bit different. So viruses come in like a whole slew of different styles, and they're really, really interesting. Like you can have RNA viruses, which coronavirus is one of them, but also we have ones that are made out of DNA. We have ones that are made out of other piece like negative RNA. It gets really goofy in the virus world. But luckily, I guess for me, RNA viruses I think are kind of most like the simple, straightforwards that make the most sense. So kind of going back to what we've already talked about, if you already have RNA as what's inside your virus, go ahead, Luke. So this is a picture of coronavirus, that like little the wound up blue stuff in there. That's the RNA. So it doesn't have any DNA in it. It only has RNA. So it completely bypasses the whole DNA to RNA to protein. It just says, hey, we're going from RNA to protein, and that's the end of that. So it totally skips DNA. And within those little that wound up blue stuff in the RNA, it has the ability to make only 29 proteins, which, for us, that's honestly nothing. I mean, we make hundreds of thousands of proteins, whereas, with this, it only is limited to 29 proteins total. And they're kind of divided up into two different categories. The structural proteins, which are the proteins that are actually make up the physical virus themselves. So like when you see the picture up in the left hand, in the right hand corner, membrane, envelope, nucleocapsid, and spike. Those are the ones that make up the physical virus. But non-structural proteins are the ones that come with it that RNA to. Can somebody please mute their phone? And I can't hear myself.
Tim,
If your name's RP, you need to mute. Thank you. Um, so the structural proteins make up the structure of the virus. But really, when I think of a virus, I think of them as like parasites because they really can't function on their own in any way, shape, or form. They really need a lot of help to, I guess, if you will, survive. I wouldn't consider them live. I consider them more of like a parasite, like I said. So basically, you have like this chunk of machinery, the virus that you see up there in the right hand corner, and basically what it does is it's going to attach to the cell, and then it's going to put its RNA in there, which you see that little red squiggle. That's its RNA in this case. Go ahead. And of course, like we said before, there's lots of proteins floating around the cytoplasm, and we have our own RNA already in the cell. And so it like these proteins are kind of floating around in the cytoplasm space, and they're like, hey, look, there's this mRNA. I'm supposed to go ahead and make some proteins off of that. Go ahead, you're gonna end up go click. So the protein's gonna go ahead and read that RNA, and then it's gonna make a whole bunch of red peas, which are viral proteins, because those viral proteins are important because a lot of what's going to happen in that cytoplasm, like the virus can't make more RNA because if you remember going back to the nucleus, that's where RNA is made, and it's sitting in the cytoplasm. So like the cell's machinery isn't going to help it out. So all those little red peas are going to go back and make more red RNAs, the viral RNAs. Go ahead. You're going to hit it a couple times until once you get all these proteins in place, then it's going to go ahead and start making more virus. So that's kind of in general how the coronavirus works. So now we're going to kind of move into how the vaccine works and how this all plays into what we've already learned about biology. So how does the vaccine work? So in this case, with the mRNA vaccine for Pfizer and for Moderna, it's actually not a full virus by any means whatsoever. I like this picture is not accurate whatsoever. So, you know, basically they have an RNA that's surrounded by some lipid molecules, so some fat molecules, because the outside of your cells are basically just all these lipids, and they can just interact one and one. And so really, we're still skipping that DNA step, but what's really cool about this is that RNA, which used to code for 29 proteins, now codes only for one. Go ahead, Luke. So here's our little cell again. Go ahead and hit again. So that lipid molecule is going to be attracted to the cell, and then the RNA that is in the lipid nanoparticle is going to be into the cytoplasm, just like kind of like a normal infection, if you will, without actual virus being present. Go ahead. And so again, our little protein is going to be in there, and it's going to still say, hey, I have this mRNA that I need to make. Go ahead. So then it's going to go ahead and only go ahead and hit 2 more times, I think. It's going to make only the spike protein. So going back to the virus, remember those were the little spikes that were on the outside of the virus. And so it's only making that one protein. So kind of going back again to what we've learned about our biology is that, well, first of all, we only have that one protein. And so we don't have all those other non-structural proteins to help make more RNA. So it can't make any more RNA. It can't replicate anymore. And so also that's great because, you know, we don't have full virus. I'm not there yet, Luke. Hold on. So we have like spike protein in there, so it can't make virus because it doesn't have all the other pieces and parts. So you're only making that one protein for spike. So the other kind of cool thing about our cells that I didn't touch on earlier is that we have this fabulous immune system. And so our immune system is always kind of checking. There's always a check and balance process. So like the cells are always kind of like, okay, what's in here right now? I need to do kind of a check. So a lot of times they will start putting different pieces of proteins up on the outside of the cell, just like what happened there. Like, so spike protein could be added to the outside of the cell, and then, go ahead. And then the immune system, I'm not going to go through all the science of the immune system, but basically the immune system is kind of, you know, spot checking all these cells, saying, okay, what do we got here? Go ahead. So immune system's going to swoop in and be like, what is this? This isn't mine. And so go ahead. Uh-oh. And so when there's that uh-oh moment, this spike protein isn't mine. That's really when the immune system really just like kicks into full gear and says, oh my gosh, we have an infection and we need to take care of this. And so that's really how that immune system gets that swift kick in the pants to start moving along. And with the go ahead, hit the button again. And like I said before, go back. The RNA is not going to just stay in your cell forever, so it's going to be kind of a time-limited thing. So, and it's not going to be able to integrate into your DNA or anything like that. So that's just really how it kicks it into gear. So let's kind of compare this a little bit to how our other vaccines work that people are pretty comfortable with. So there's kind of 2 different types of vaccine that people are most familiar with. So number 1, live attenuated virus. Basically, it's a weakened form of the virus, and you have an actual infection when you get inoculated. Go ahead. And so some of the vaccines that use this technology are MMR, so measles, mumps, rubella, rotavirus, smallpox, chickenpox, and actually my favorite, yellow fever. So basically, to get a yellow fever vaccine back in the 20s through 40s, basically they just kept passaging virus through cells until they got to a point where the virus wasn't all that harmful. So it's actually full yellow fever virus that you're getting injected with, but it's gained mutations over time so that it, like, you get an infection, but you don't really get the symptoms along with it. So these are actually really good at eliciting an immune response, and that's why in some cases people really shouldn't get them potentially if they have a weakened immune system or anything like that. Go ahead. The other type of vaccine that we're pretty familiar with is what we call inactivated virus, or killed. So actual virus is treated with either heat or chemicals to render it, you know, inactive. So it's not actually, like, when you get injected, there's no, like, the particles are going into you, but it's not able to actually infect you. Like, it can't get in the cells, it can't replicate, it can't do any of that. And so some of the vaccines that are associated with that are, go ahead, hepatitis A, the flu shot, not flu miss. Flu miss is actually live attenuated. Polio, the shot, and also rabies. Go ahead. But one thing that I really want to hit on, and I'm not going to go through a lot of this because I want to make sure that everyone else has some time to talk. Safety has been a huge priority for vaccines for forever. I mean, like, it is of the utmost importance that we have safety. And I just want to point out that like even when they're starting the basic research and the discovery and the preclinical studies, they're already looking at how this can be done safely. So thinking about how an mRNA vaccine would work is that, I mean, honestly, it's already using processes that your cells already do. And so I think that makes a lot of sense. And then once you move into the clinical studies and trials, which have been completed already, you know, phase 1 specifically is on safety. Phase 2 is on effectiveness. And in terms of the pandemic, I know that they tried to overlap those a bit just to try save time because we have so many people dying. There is an ethics portion of this too that we want to make sure that things are safe and effective, but we also need to balance out loss of life. So it's still kind of a balance. And then phase 3 was looking at safety and effectiveness at the same time. And then we went through the FDA review last week and also the ACIP review for the Pfizer, and hopefully the FDA review for Moderna will be done this week. And even after vaccines start rolling out, which some of them already have, I mean, they're still going to be monitoring in terms of safety. Go ahead. So I just wanted to hit a couple FAQs, myths, and rumors. So is the vaccine a live virus? Nope. It's only like one molecule of RNA that has basically kind of fat surrounding it. As a person who has made a lot of RNA in their day, RNA's finicky. It's really finicky. And so it makes a lot of sense, honestly, that it would be stored in very cold temperatures because they want to make sure that the RNA stays intact. But other vaccines we've been using for years include live virus, but this one is not. Kind of along with that speed thing, like I just alluded to, like I've made a lot of RNA in my life. I can sit, if you let me and give me the right tools, I can make you a number of batches of RNA in one day. Whereas with a lot of our other vaccines, like especially the live virus ones, we have to like inject chicken eggs and then we have to wait for a long time. And so really some of the speed that has moved this along is the fact that you can make RNA in the lab and you don't have to wait so long to get like a live virus out. Will the viral RNA and the vaccine integrate in my DNA? Nope, they're two totally different molecules. They're located in different parts of the cell, so there's not really that potential to happen. And also, I've heard, is there a microchip involved in this? And my answer is no. Like one of the ones I've heard is that the vaccine has a microchip in it the size of a grain of rice. If you've ever administered a vaccine or gotten one, if you had to get a needle gauge the size to actually have a piece of rice in it, that would hurt quite a bit. So that's the end of my presentation, and I just had a piece in there just for one of my sources that I stole a picture from. So with that, I will turn it over. Do I go back to Luke or just straight to Jennifer and Tony?
Awesome. Thanks, everyone. I'm Tony Bultice, the immunization supervisor at Ottawa County Department of Public Health. And this is our a little bit on the storage and handling of the COVID-19 vaccine, which I can attest to because we just unloaded some of it. So we will go ahead with this. During storage, especially during frozen storage, which we were finding out it's kind of difficult to do, but you're going to minimize the exposure to room light. Although we watched a Pfizer video that did say it can be exposed to room light. Obviously, we don't want to expose it to a long time in that light, but it's just avoid exposure to the direct sunlight and ultraviolet light. But the videos that they were showing, actually, they were in the refrigerator, not protected from light, but obviously when you close doors, et cetera, it will be a little bit darker. And so you just want to minimize that exposure. We cannot refreeze the thawed vials at all. So once they are thawed, they will not be frozen again. And the frozen vaccine can only be out of the frozen environment for 3 to 5 minutes. 3 minutes if it is a partial opened tray of vaccine is 3 minutes. So if you have to take it out, get some vaccine out that you're going to thaw, close it and put it back in, it's a 3-minute window. If it's a closed tray, it is a 5-minute time frame that it can be out of the frozen environment. Once you take it out and do whatever you need to do with it, and put it back into the freezer, it needs 2 hours in that ultra cold frozen environment before you can remove it again. So the most important thing to remember, especially if you're going to be having clinics, days of clinics, is you want to prepare and know how many doses you have that you're going to be giving. So you're going to decrease the times that either your freezer is opened or your container needs to be opened. The video that it's really self-explanatory. It's really helpful. I linked right there from the Pfizer website, and that is very explanatory. And there's a couple more of the videos on there also. So this is a vaccine that we're going to give at day 0 and day 21, which is different than other vaccines that we're all used to giving, which are either 1.0 mLs or they're 0.5 mLs. This one is a 0.3 ml IM injection. And it can be given, we want day 0 and day 21, but there is, we don't want to plan for it, but there is a 4-day grace period. So it can be given anywhere between day 17 and day 21, and those doses will count. If you don't give it by day 21, you want to give it as soon as you can after day 21. And you don't have to restart the series at all. The dose preparation for this, it's a frozen suspension, and it does not contain any preservatives. So it's that's why it's frozen, must be thawed and diluted prior to administration. So we're going to be, the thawed suspension can look like it's got a little bit of white, little tiny particles in there, and that can be normal, but if it's any other color, anything else seen in it, you can't use it. The contents are going to be diluted with 1.8 mLs of the sterile 0.9% sodium chloride injection. It is only the only one to be used is what comes in the ancillary kit for it. There shouldn't be anything that you use other than the specific diluent that you get with it. After you dilute it, that vial is going to contain 5 doses of 0.3 mLs. So you're going to count out your doses by 5s when you take those vials out of the package. And so that ancillary kit has all of those, all the diluent in there. Actually, it comes with a lot more than what you need. So if you drop one, break one, you will have plenty. So it's good to know. And then the vaccine might be, once it's diluted, it's going to have it be an off-white suspension. You just want to make sure there's no particles in there. You just want to make sure that it looks the white color. You don't want it to be yellow, don't want it to be pink, and you really have to use aseptic techniques because there are no preservatives. And because there's no preservatives, once we dilute it and reconstitute it, it's got 2 hours out of the fridge, it's got 6 hours in the fridge, and that's it. Then we have to pitch any doses that are left in that bottle. And like I said, right there, no more than 2 hours at room temperature. Once it's reconstituted, it can go back in the refrigerator though for up to 6 hours. So what we have to do though, when you thaw the vial, you can either thaw them for 3 hours in the refrigerator, move it directly from the frozen environment, whether you're still using the shipping box with the dry ice or you have the ultra cold freezer. You're going to take it and move it directly into that refrigerator. It's a 3-hour thaw for a full tray. It will be less time for a thaw if it's not a full, if it's less than a full tray. So they're saying anywhere between 2 to 3 hours depending on how full that tray is. Or if you're going to take it directly out of that frozen environment and put it at room temperature, you can thaw it at room temperature. It'll take 30 minutes to thaw, but it still might be cold, and we know it's going to be cold coming out of the refrigerator too. So it actually has to come to room temperature before you reconstitute and dilute. And so we have to kind of look at that and kind of pay attention while we are, starting to get into the reconstituting, but make sure it's to room temperature before we dilute it. So it's going to take a little bit more time than just your 3 hours or just your 30 minutes thaw time. So after we dilute that, it's going to be either at room temperature or in the refrigerator, totally fine. 2 hours at room temperature, 6 hours from the time of dilution. During storage, we want to minimize the exposure to room light. After it's diluted, it's okay. Room light is okay. We don't want to have it sitting out for too long, but in the refrigerator is great, 2 hours max. Any vaccine remaining in those vials must be discarded after 6 hours and cannot be refrozen. No, we have to avoid exposure to direct sunlight and ultraviolet light also. So this is the process of how we're going to have to dilute. So even before we reconstitute or add the 0.9% sodium chloride solution to dilute it, it has to be inverted, and they don't want us to shake it. They want us to just invert that 10 times. And it's like I said before, it's going to be that kind of off-white color, might have little tiny particles. Don't use if it's discolored, pink, yellow, anything like that, or if there's larger, thick particles that are observed. They have supplied in the ancillary kit, which is great. We dug through ours yesterday, that there are 3 ml syringes specifically for diluting. Then there's also syringes that are smaller, so that on a smaller range, so that you can easily draw up 0.3 mLs. So you're going to use the 3 ml syringe and needle to draw up your 1.8 mLs of the diluent and transfer it into the vaccine vial after cleansing it with an alcohol swab, and just a one-time use. You don't reuse those at all, and you're going to add that into the vaccine vial. You record the date and time of dilution. There's labels on there, and so that you write when you diluted it, your date and time, and then you store it, and you discard any unused vaccine 6 hours after dilution. There is the website that we use for a lot of our information for that, and that's that Pfizer CDC site. Tons of great information on there. And one of the most important things too is obviously our temperature monitoring. And so for frozen vaccines, for this particular vaccine, it is going to be, it has to be held at -60 degrees Fahrenheit to -80 degrees Fahrenheit. Or that's -112 degrees, sorry, that was -60 to -80 Celsius, and then -112 to -77 Fahrenheit. And so that's where it's held. These, don't pay attention to these numbers right here, but you want to make sure that your freezer, if you have that ultra cold freezer, is that it's set at the midpoint between those two temps. So our freezer we have here, we set that midpoint temp at -70, because that's right between our -60 and -80 Celsius. We document our temps in Fahrenheit, so it's a little bit confusing, but we put up a sign on our freezer so that we know what our temps need to be and what range they need to be in. We also have a data logger on our refrigerator, so that we can download the graph as to the history of the temperatures from the time that we're away. So overnight last night, we were able to come in, document our temperature that was on there, and then we also downloaded the data logger, and we were able to check that graph and make sure everything was stayed within range. So also what is required is that you check and record your minimum and your maximum temperatures at the start of each workday. Minimum is the coldest temperature that it is, and maximum is the warmest temp in your fridge from the last time you reset your thermometer. Now, some of these are data loggers, some of these are certified thermometers, but you want to make sure you know on your actual device how you're going to reset that 24-hour temp, or since the last time you were in, so that you know the maximum and you know the minimum temperatures that it has been since you have checked it last. And that's really important to know, to reset that. And then your current temperature, every time you go in the fridge or freezer, you're going to be checking that temperature so you know that it's in range. And temperature monitoring, you know, this is so important. As a immunization nurse, we have our phones on all the time. We have a phone tree as to the alarm system that is set up with ours for our vaccine in case it goes out of range. One of us gets a phone call, and it has a phone tree for all of us in case somebody's not available. And you know, we don't necessarily have to have that for this COVID vaccine, but if you're thinking about having vaccine in the future, it's something to have, is have a system set up and the technology so that you can be called if your vaccine goes out of range when you're not in the office. And if it does go out of range, you guys can contact us at the health department, or Mary Wazinski over at Kent. She's awesome, because we can guide you and into what your steps would be for a temperature excursion. Manufacturers are really good at helping with that and giving us information about that too. And just best practices, always good to just take your time when you're checking your temps. Don't be rushed. Have a little your temperature log right near you, when you're checking the temperature, so you don't have to walk back somewhere and kind of try to remember what your min and max was and your actual temp. And so, and document that you were the one that did it and when you did it, because it's important that we always have that monitoring in there and who is checking it. And, if min max temperatures were not recorded, you're going to leave it blank. We don't want to lie about checking the min max temps. Some on our data logger, I can actually go back and look on the data logger on our graph, but some people don't have a data logger, so we totally understand that. But at least I have a double check if we do miss something, and that's always good to do too. But if you guys are looking into having a data logger, let me know and I can help you with that too. Mostly for those who have ultra cold freezers and units that, for obviously for your temporary storage containers right now with the dry ice. You don't need to do that, but you just have to follow the directions for refilling and how often you need to do that. I think that's it. And here are all of our resources.
So as Luke mentioned, I am the medical director for District 10. I also am the medical director for Central Michigan and Mid-Michigan District Health Department. I was asked to talk today about the importance of getting the vaccine for COVID-19. As you know, as you've heard today already, right now that's the Pfizer vaccine, and the FDA is actively discussing the Moderna vaccine as we speak. I don't really need to tell you that a lot of people are getting COVID-19 in the United States. This is the daily case counts in the US as of the 14th, and a lot of people are dying from COVID-19 in the US. And the same is true for Michigan. We're doing a little bit better job than the US as a whole at controlling our cases. And unfortunately, we have people dying in Michigan from COVID-19. So again, this is not shocking news to the people on this call. This is just some interesting data. I'm sorry if I clear my throat a lot today. Some of our deadliest days in US history have been due to COVID. This is by far not all of our highest death count days, but I had to stop somewhere. But our death counts on specific days have exceeded our death counts due to D-Day, due to September 11th, due to Pearl Harbor. The Spanish flu really caused huge amounts of mortality in the United States and the world. Our healthcare system then was nothing like we have now. We're about to half of that death rate at this point. So again, I know I'm preaching to the choir on this, but just to really illustrate the importance of having something preventative at this point. The top 3 causes of death in the past years per the CDC have been heart disease, cancer, and accidental deaths. COVID now is at about half the rate of deaths by cancer. So it has surpassed our 3rd leading cause of death at this point. So we are getting to a point where COVID is, definitely a huge cause of our national mortality. So besides just illness and death, there are some other long-term consequences of COVID that we may not be thinking about. There is a post-acute and chronic COVID syndrome. You may hear of it called long COVID or long-termers. So post-acute COVID is illness that lasts longer than 3 weeks. Chronic COVID is illness that lasts longer than 12 weeks past the onset of symptoms. It can occur in anybody. It does not have to be someone that is elderly, that has pre-existing conditions, or someone that's been in the hospital or in the ICU. The most common persistent symptoms are fatigue and shortness of breath, but it can also be cough, joint pain, chest pain, other things like that. Oftentimes these individuals have multiple organ systems that are affected. The heart is particularly sensitive to this virus. Myocardial inflammation, myocarditis, cardiac arrhythmias have been noted, even in, again, young, healthy people. Obviously, the lungs are impacted. People have the persistent dyspnea, cough, but even damage to the lungs like fibrosis, thickening, which then leads to diffusion decreases. So basically, you're not able to get oxygenation through or get your CO2 out. The lung muscles are weakened. Neurologic issues have been common, and it's speculated, as we see that lack of smell and taste, that the virus may actually be permeating up through those nerves and into the central nervous system. People most commonly will complain of persistent headaches, dizziness. The lack of smell and taste can last for weeks and weeks in people. There have been strokes. In fact, one of our nurses had a friend whose husband in his 40s with really not any significant comorbidities die of a stroke as a consequence from his COVID illness. Encephalitis and seizure can be consequences, but that brain fog that people complain of can last for quite some time. So essentially, it is like a chronic fatigue syndrome illness that persists. And whether it's from the COVID itself or just the chronic illness and the stigma that goes along with COVID, people are often suffering with depression, anxiety, mood swings, and a lot of stress from this. Michigan has been working on a study of Michigan residents with COVID. It's been a joint venture with U of M and MDHHS. And so they randomly pulled cases from MDSS. They pulled them up to mid-April. They surveyed them between June and September, so it was at least a few months after their onset of illness. At that time, a quarter of them had not recovered yet, and the ones that had recovered, it took an average of 4 weeks for them to recover. The range was 1 to 18 weeks. So for those that had not recovered yet, the symptoms are listed here on the right. So half of them were still fatigued. So they're continuing to follow these cases in Michigan. But again, those are random cases. A lot of them were, considered mild illness. And, the amount of disability, lost work days, cost to society, these are all consequences to society that we don't think about a lot of times when we're talking about COVID. So another study that's come out looked at, I love this, it says young people, so average age of 44. So I love to think of that as young, makes me feel good. So low risk individuals, the pre-existing conditions were low. 20% of them were obese, which is below the Michigan average for obesity. Very few had any other health issues. And they looked at the ones that had ongoing symptoms, and 70% of them had persistent impairment of at least one major organ system 4 months after the onset of their COVID symptoms. Very few of them were hospitalized. Most of them had fatigue still. So again, it's not just that they still have symptoms, but they actually have signs of organ malfunction for months. This next image is quite interesting. You have to have really good eyes to see this, but some of these, like this person here has a little skirt. This one has little pants. So it does differentiate who's female and male in this study. The red characters are the ones that were in the hospital. So all these other gray characters were the ones that were not hospitalized. So the majority were not hospitalized. So the people in this chunk were the ones that had signs of heart organ problems. This is green circle is pancreatic, purple is kidney, and the brown is liver. And where they intersect are the ones that had multiple issues. So like these three here had pancreatic, liver, and heart. Well, actually the heart doesn't overlap there. So it looks like everything but heart. So again, this is just an interesting image to help visualize that. But just, to imagine people that are, in their 40s, no other comorbidities, not hospitalized with COVID, and 4 months later still dealing with organ dysfunction. And so I think that's the biggest thing with COVID is that we just do not know what this is going to do to people in 1 year, 5 years, 10 years. And so regardless of the number of deaths and hospitalizations we're seeing, that's to me another big reason why people should get vaccinated is because you just don't know what this is going to do to you. This is very busy, but just another visualization of the other things that COVID is doing to us. These are kind of the repercussions of the pandemic. So what happens when we close schools? What happens when we don't have transportations, when we don't have non-essential services, when people are stuck at home, when people get sick? We're seeing substance misuse, gambling, overdoses, lack of education, loneliness, depression, suicide. So this is just, all these trickle-down effects. Again, more and more reasons why we need to stop this pandemic. So this is from a review article about vaccination. The author was Dr. Ornstein, who is the director of CIDRAP. Vaccines to prevent SARS infection, SARS-2 infection, or COVID are considered the most promising approach we have to controlling the pandemic. So this is our silver bullet. I think we've all put all our hopes into this. We're all really hopeful this is going to be our saving grace. So we need to do all we can to get this up and running and in people's arms as quick as possible. Another good quote that I've heard is, the vaccines are not what's important, it's the vaccinations that are important. So the vaccines in a vial in a freezer aren't going to help anybody, but we need to get them in people's arms. So this study was just published the end of November, and it does a really good job of modeling what we can expect from vaccination. So what is the impact going to be? So it looked at numerous different groups of individuals, different age groups, people that were still susceptible to infection. Are they going to get vaccinated, not vaccinated? Are they infected but not infectious, pre-symptomatic, asymptomatic, et cetera, et cetera. So it looked at a lot of different variables. It modeled a 2-dose vaccination series, a series that needed to be given 28 days apart. It assumed that about 40% of the population was going to get vaccinated. It modeled that we'd start with healthcare workers, then go to people with comorbidities, then go to people over 65, and then get back to those that were 18 to 64. They assumed that at best, up to 70% of people in any age group would get vaccinated. So kind of the worst case scenario. They assumed that 40% was going to get vaccinated, but at best up to 70% might get vaccinated. So with their modeling, they predicted that 18 to 19-year-olds would, on average, about 38% would get vaccinated. Our middle-aged individuals would be about just under 50%, and our 65 and older crowd, about 70% of them would end up getting vaccinated. They estimated that 80 per 10,000 vaccines would, people would get vaccinated per day, 6 days a week. So that would end up being 15.7 million vaccines per week for 15 weeks. So through the end of March, that's exactly to the end of March. The directors of Operation Warp Speed have been quoted as saying that they expect to fully vaccinate 100 million people by the end of March. So that's 2 doses by the end of March, the 200 million vaccines. This estimation that the people doing the study did equates out to 235.5 million doses by the end of March. So their study essentially is pretty spot on to what Operation Warp Speed is expecting to accomplish. So basically what I'm saying is this study models essentially what the goal for our country is. So they estimated in this study that the vaccine rate would be 90% 1 week after 2 doses, which is pretty darn close to what is reality. It's a little bit under what the studies have shown. They did estimate that it would be about 45% effective after 1 dose. They did down estimate how effective it would be in people that were 65 and had comorbidities. That has not been found in studies. They found it was pretty close to the same effectiveness in those with comorbidities and those over 65, though, the studies have been done in tens of thousands of people, not tens of millions of people. So they did down estimate it on the same scale as we see traditional influenza vaccines being less effective. They also assumed that vaccination would reduce the risks of severe illness and hospitalizations, which the studies have shown it did reduce risks of severe illness. But again, they only had, a handful of severe illnesses in the studies anyway, so that will pan out more, as we have more data. They assumed that the immunity from the vaccine will last over a year. They assumed in general that the pre-existing immunity in the country was 10%, but they did do different simulations, which I'll show you here in a minute. And they also assumed that the reproduction number for COVID infections was 1.5. So basically for each case of COVID, that person would go on to infect 1.5 other people, or about 1 to 2 people, which is on the lower end. That's assuming then, in my mind, this is them assuming that we're going to continue to mask, continue to do physical distancing, continue to do all the other things we've been doing to prevent COVID infection. Because if we don't do those things, the infection rate is usually more towards 2 to 4. So that's an important point in my mind, is that we need to continue to do our other preventative measures. So what did they find after doing all those assumptions? What did the math find? So vaccination would prevent over 556 infections per 10,000 people. So basically, if we do fully vaccinate 100 million people, we're going to prevent 5.5 million infections. So the rate of infections in those over age 65 is going to reduce 83 to 90%. That would be the biggest group affected, which is good because that's one of our highest risk people for complications and death. Even though children under 18 were not modeled as being vaccinated, their rates would actually decrease by 50% because of the herd immunity. If you protect adults, they're not going to infect children. So that was an interesting thing that they did find. Non-ICU and ICU hospitalizations would both go down by 85%. Deaths would go down by 88%. And they did modeling that even if we only shot for 20% of the people getting vaccinated, hospitalizations and deaths would go down in the 60 percentile range. So we'd see even that as a benefit. So here's some images. The blue line is assuming that our pre-existing immunity in our population is 5%, red line is 10%, green line is 20%. You can see really the biggest effect of the community immunity is in children because they weren't getting vaccinated. So they rely more on our herd immunity. But you can see that, this is the percent reduction, and it really has just a huge effect at all age levels, at least 60% reductions. But it really is our, older adults that have the biggest reduction in infection rates. This left side is if we assume 5% community immunity. Middle one is 10%, and the right one is 20%. So I'm just going to focus on the middle one because I think that's most representative of our overall areas. So the black line is what we would expect to see in our case rates if we don't vaccinate. The brown line is with vaccination. So it's the incidence of cases. So just unbelievable crushing of the curve here. So almost too good to be true. But again, the modeling that they used, I think, is extremely reasonable expectations, as we reviewed just a minute ago. On this left side, graph A is non-ICU admissions, graph B is ICU admissions, and graph C is deaths. The first line is if you assume 5%, 10%, and then 20% community immunity. So we're just going to look at the middle one. The whitish bar is without vaccination, and the brown bar is with vaccination. And so it's the rates of hospital admissions and deaths. So again, just immense reductions in the rates of hospitalizations and deaths with vaccination. So I put this in here. One of these did come out from Michigan, and I meant to throw it in here, but I just did not because it just came out late yesterday. But this is a recent survey of the U.S. Of intentions to get vaccinated. So the question was, after the vaccine becomes available, do you plan to get it? 27% said, yes, I plan to get it as soon as it's available. Noting that in September it was 13%. Now, don't be bummed that it's a really low number. We had others that said they'll wait a few weeks or a few months or a year. People are always a bit nervous about a new vaccine, and 21% said that they won't get it at all. The numbers for Michigan were higher for this. I believe it was in the 30 percentile range, saying that they would get it as soon as possible. But again, that just came out yesterday. The higher age groups are more likely to get it. And again, that's what I would expect, just because they are more at risk for those complications. But it is important that we keep messaging safety and the importance of getting it, and the safety monitoring that will be going on. I did put in numerous different links here. The Infectious Disease Society of America has a really nice page that has links to numerous sites, including the Pfizer site, the CDC site, and multiple other sites. And then Michigan has their own site with a lot of information as well, and talking points. For Moderna, the FDA Advisory Committee has the documents, multiple documents already on their site that they're reviewing today, but that reviews a lot of the data. I haven't looked at it yet. I hope to look at that today, but it'll have a lot of the data for the Moderna vaccine on there today. But hopefully we'll know more about that by the end of the week in terms of their decision and then the ACIP decision. I just put this up here as a reminder. Again, just because we have a vaccine and we're using it, we still need to follow all of our other preventative measures until we have enough people vaccinated and we know that it is preventing spread. Otherwise, we're going to have another surge and we're going to lose control of things again. So I just put that up as a reminder that we do still need to follow all of our preventative measures that we know are helping. It's just not stopping our pandemic like we hope it would. So that is the end of my presentation.
Great. Thank you very much, Dr. Morse. At this time, we are going to enter the question and answer session. If you have a question that you would like to ask, please use the raise your hand function on Teams, and we will call on you. The first question we have is going to be from Teresa. Teresa Martin, go ahead and unmute and ask your question, please.
Hi. So I'm taking that people who have had COVID already need to get the vaccine yet.
And Dr. Morse, can you answer that?
Yes, it is recommended that people who have been infected do still get the vaccine. It is recommended that if you are currently ill with COVID, that you wait until you have clinically recovered. If you have tested positive, it is recommended you wait until your 10-day isolation period ends. Also, since at this time, we're not really seeing reinfections for 90 days after you've been infection, if people wish, they can wait and get vaccinated 90 days after their infection if they desire. It is not a recommendation, but it's more a patient's preference.
Thank you.
Mm-hmm.
Great. And Tim has a question on the chat. I've heard a lot of potential side effects from this vaccine as extreme as Bell's palsy. How much data do we have about the percentage of people experiencing these side effects? What are the known side effects of the vaccine? And I'll put that back to Dr. Morse.
So I'm just trying to pull up the actual numbers because I have them right here. There were 4 cases of Bell's palsy that occurred in the test subjects of, over 22,000 people got the vaccine. No cases of Bell's palsy occurred in the placebo group. And so it's really not known, because people get Bell's palsy in the normal population. So that's one of those where they're going to follow that very, very closely. And it's not really known if that was a cause or effect. But that is something they're going to follow very closely. So 87% 85% of people had at least one local reaction. And that would be things like pain at the site of injection. Like I said, I'm trying to find my slide. I had it all nicely laid out here. Anyway, I'll just go right through. But a lot of people did have pain at the site of injection, swelling at the site of injection. Most people did not have it severe enough where they had to take off time from work or things like that, but that was a potential. Individuals also had risks for fever. I'm looking right at the numbers here. So between like 1% in those that are over 55 and around 15 to 20% of those between 18 and 55 had a fever. I'm just looking at the percentage. I'm sorry, I don't have all this memorized yet. Our immunization coordinator might have it more memorized than I do because they but long story short, I'm trying not to hold up the discussion here because I'm looking at tables right from the manufacturer, and it's pretty complicated here. But yes, there is.
I could jump in with a couple I pulled from CDC yesterday.
Yeah.
Just for Pfizer only, 4.2% of people had fatigue, 2.4% had headache, 1.8% had muscle pain, and then for chills, 1.4%, and also injection site pain was 1.4%.
Okay.
Those
yes, we do expect, it is a very what we call reactogenic vaccine, so it really kind of kicks your immune system, and so you have kind of like those flu-like symptoms for a day or two. Usually those are not lasting longer than that. And there is some consideration though given to when you get your vaccine. So if with COVID screening, you can't go to work if you have a fever, if this might cause fever, you may want to give consideration as to when you get your vaccine. So I know a lot of healthcare organizations and workplaces are considering timing of vaccine based on those things. So hopefully that answered your question. If not, please add to the chat.
All right, there are a couple more questions. The pharmacy does not recommend giving the COVID vaccine within 14 days of another vaccine. Can you clarify if this includes PPD, which is the skin test, TB skin test? And that comes from Danielle.
So that has not been specified, but the issue with co-vaccination is that it's not been studied if how it will interact with efficacy or side effects. We can clarify that with our immunization experts at the state, but my feeling on that would be I would wait the 14 days simply because if it does blunt your immune system, because the issue with that with our live vaccines is that your immune system might be so busy working on the vaccine that it's not able to respond to a TST. That is a very good question though, and I will take that back to our state immunization experts to answer that question.
And we have a question from Michelle Cassins. Michelle, go ahead and unmute and ask your question, please.
Hi. When will we learn more about administration clinics? So specifically for employers, if you are an employer of essential workers, will there be community clinics we can send our employees to? Do they have to show proof that they're an essential worker? How will we know when phase 1B starts, phase 1C, that type of information, please?
Michelle, this is Jen Sorick. I can answer that one for you. This actually is all being decided by the state of Michigan and through the ACIP. Currently, we are in phase 1A, priority 1, which is EMS and hospitals. In that hospital group, it is general med floor, it is EDs and ICUs. That is the first priority group. Priority 2 is long-term care facilities, residents, and staff. And then priority 3 is the general healthcare providers. And we're really sticking with those groups. And then, so we're currently in the priority 1 group. We suspect to be through all of phase 1A, which is all 3 priorities within about 0 to 5 weeks, and into the 1B, which is the essential workers, in about 5 to 12 weeks. It may take some of us a little bit longer if we have a larger population. Some smaller populations, it may take a little bit less. We do not have to fulfill 1 full phase before we move into another phase. It also is dependent on whether all of those people in that phase range want the vaccine. So there's a lot of things that are dependent on moving through these phases, and it's also dependent on the priorities and how the priorities are listed. So the ACIP will, which is the immunizations organization, will help us prioritize who is in each of the phases. And then the state of Michigan will help us also prioritize the levels. So we knew that long-term care residents and healthcare providers were in phase 1A. Then the state of Michigan put the 3 priority levels in for the health departments to follow. We suspect that the same thing will happen in 1B. There's a little bit of wiggle room for public health, not a ton, depending on if some of the industries fall within multiple levels. If they do fall in multiple levels, we can make some decisions, but it's very little wiggle room based on those kind of delineations. But there is, if you look at the state of Michigan's guidance, there's kind of a wave chart that kind of says when we'll get into those areas, and then we'll be working to contact each of those kind of areas. I know in Ottawa, what we're doing is we are verifying each of the individuals in those areas. So right now we're working on EMS and medical first responders. They are being ID checked as they come in. And then we have a list of all of the employees that work. We got a list from all of our fire departments who are medical first responders and EMS. And they are being ID checked. And if we do not have their name from their employer, they're not getting the vaccine. It's just the only way to make sure that the right people are getting the vaccine in the first criteria as we move through the criteria. And then we're working to try to get all of our healthcare providers. So if you're an Ottawa County facility and you have not filled out your survey, fill it out, please. If you don't have the survey, email me. We're still trying to get some of our healthcare providers who are independent to get those surveys back to us. We sent out a survey, and once we get to that priority 3, they'll all get an email with the link to sign up for an appointment, and then we'll do that process. So that's kind of how we're going through it. I don't know if
Jennifer,
hold on.
We're a healthcare provider, but we're in multiple counties. So how do we do that?
So why don't I, Jen, in the interest of time, if you want to go ahead and send your message to me with the counties that you are affiliated with, I'll be happy to send them to the appropriate people.
Thank you very much.
Thank you.
Thank you. Sandy, you have your hand up. Go ahead.
I think Jennifer mostly answered my question already, but I guess just to clarify, so I did a survey, I filled out a survey through Holland PHO for Hospice of Holland employees that are healthcare. Is that the survey you're talking about, Jennifer?
No, we actually sent a survey from Ottawa County. It is ours.
Okay, I don't think I ever got that.
Okay, Sandy, if you want to send me a email, I will have Phyllis send you another one.
All right, thank you.
We have a question on the chat. When someone is vaccinated and if they become symptomatic, fever, muscle aches, so forth, is it recommended to get COVID tested or quarantine regardless of having received the vaccine? So let's do Carla.
So the CDC put out some guidance I believe on December 13th. There's a pretty nice document out there already. So it kind of breaks it down into 2 tiers. So with vaccine, you can expect potentially that you might have like headache, muscle aches, some fever, other things like that. However, and so that if you get things like that could be indicative of COVID or indicative of the vaccine, you should probably have kind of talk with your work and think about what that means. You know, and have you had any exposures within your home or things like that? So kind of making more of a risk-based situation. But if you end up with the cough, the shortness of breath, loss of smell or taste, that is absolutely indicative of COVID, and you should not be working.
All right, great, thank you. I do not see any more questions in the chat unless I missed one. Does anybody have any questions they would like to ask? Feel free to raise your hand. And we have a question from Michelle. Michelle, go ahead and unmute and ask your question.
Sure, thank you. Just could you address again, as we go forward through this period of time giving the vaccine, the administration clinics? I mean, I've read that the Walgreens, CVS's are all going to be involved. So how do you see that evolving and developing as we go through the phases of administration?
Carla or Jen, which one wants to tackle that one?
I guess I want some clarification. I'm not really understanding exactly what your question is. I'm sorry.
Well, regarding administration, so we have this huge mass of people that are going to need to be vaccinated. And initially, it sounds like the health department and the large healthcare systems are the ones that are receiving vaccine. But eventually, we're going to be going through more of the levels of people who can receive the vaccine. So what is this going to look like in our communities? People are asking a lot of questions about that.
Okay, thank you for your clarification. That helps me. So just because right now in phase 1A, tier 1, and even as we start moving things out a little bit, like we're pretty limited at this point. And so a lot of what we're going to be doing is working very closely with our specific population. So like for the local health department's EMS. So Jen kind of explained a little bit that. So it's going to be kind of more of a closed pod situation. But as vaccine becomes more available, and also as other vaccines are becoming available, for example, like Tony was talking about, the storage and handling of the Pfizer vaccine is incredibly tough compared to other vaccines that we've had in the past. So like Moderna is hopefully going to be coming next week. That is only held at -20, so it's not nearly as finicky. And so therefore there are going to be a lot more opportunities for other places to be able to house vaccines themselves. So like in the state of Michigan, I think only 11 or 12 health departments that were getting Pfizer because we had -80s, whereas a lot of the health departments didn't. So they're going to be getting Pfizer. So that will help get that further out into the community. And as more vaccine becomes available, we will probably see more opportunity for physicians' offices, specifically at pharmacies, and also us being able to work with partners to push it out that way as well. So we're going to be moving kind of from these like small closed pods, and even like as we head into like the 1B category, if somebody's not covered, not 1B, sorry, tier 1A level 2, that has, you know, the homes for the aged, things like that, we're seeing kind of more as a like a strike team situation if, you know, pharmacies can't reach them if they didn't sign up. But then as we hit tier 1A level 3, when we start getting into some of our broader categories, I fully see that we're going to be kind of implementing like larger pod models to get people through, or hopefully by that time their own locations will be able to receive their own batch of vaccine, hopefully, or us being able to transfer it to them.
Right. And to say what Carla was kind of reinforce what Carla says, we call it a pull and a push model. So right now we're doing a pull. We're pulling you all the public health because we're the ones that can, or to a pharmacy who can with like hold that really cold vaccine, or a hospital.
Sure.
Eventually we would love to go to a push model where your patients can go to your doctor's offices. We can send patients to a pharmacy. We can do larger clinics. We can have it within the community at a large spread so that it's not just at a few locations, but it's everywhere. But we kind of have to let the vaccine catch up and get enough vaccine to the point where we can blanket it out there to do that. So it's kind of like the speed up, slow down method. And we call it a push and a pull model. So we're pulling right now to get all the vaccinators, what we call it, vaccinate the vaccinators. We get all the healthcare in, vaccinate those people so that you're ready to go when we get to the point where you can get your own vaccine, and then we push it all out so that you can vaccinate the public with us.
Thank you so much.
And thank you. I did miss a question from Jesse, and thank you very much, Tim, for bringing it to my attention. Any recommendations on who should not get the vaccine other than active infections? Wondering about immune compromised, autoimmune diagnoses, and those who have had other severe reactions to other kinds of vaccines. Dr. Morse, why don't you take this one?
Sorry, I had to get off mute. So people with autoimmune conditions, it's kind of a shared decision making with their healthcare provider or the health department. We don't have a lot of data on it. We don't know how effective it will be. It is not a live vaccine, as was mentioned, but we don't know a lot about safety. So it should be safe because it's not live, but again, there's just not a lot of data. And the main part of counseling, though, would just be that it may not be as effective. The official contraindications, like I said, I don't have all these memorized yet. There's a nice table on the CDC website. So the ones that absolutely should not get it are those who have a history of a severe allergic reaction, such as anaphylaxis, to any component of the vaccine. The tricky thing with that is that the main components that you would be allergic to would be either the RNA, which would be highly improbable, or the lipid components, which I've tried to find what other things the lipid components would be, and it really is, I can't find that. So you likely would not know if you're allergic to it until you get it. Precautions are similar to other vaccines. So moderate to severe illness, history of severe allergic reactions such as anaphylaxis to any other vaccine, history of severe or allergic reaction to an injectable therapy, and those that are able to proceed with vaccination. You can get vaccinated if you have an immunocompromising condition. Pregnancy and lactation are conditions, again, that we don't have data on, but you can discuss the risk benefit with your provider. You can proceed with vaccination if you have history of food, pet, or other allergies that are not vaccine or injectable therapy, or if you have a history of an allergy to an oral medication, or if you have a history of a non-serious allergy to a vaccine or an injectable, so like a rash or a local reaction. We would just ask that if you do have those, that you would wait for a longer period of time after injection.
Great, thank you very much. In the interest of time, I think we're going to go ahead and cut off the questions at this time. If anyone does have a specific question, feel free to email the local health department that your facility is in. Each health department does have a COVID-19 email. And then if you don't know where to send your question to, feel free to send it to me. I can put my email in the chat or any of the emails that came along with this meeting invite. I'm just scanning real quick to see if there were any quick questions. Yeah, let's do one more question. Jennifer Robinson, do you anticipate testing capacity being reduced due to the vaccination effort, or do you anticipate testing availability will be maintained at the current level? I can actually answer that. The idea is to maintain testing at the current level. All right, I do want to thank everyone for your time today. Special thanks to all of our presenters from Region 6. Again, if you do have any questions, feel free to email your local health department directly, or you can email the region. My email is lorner@wmrmc.org. I will go ahead and put it in the chat. Again, thank you all for your attendance, and we will talk to you soon. This meeting recording will be sent out to the group to be shared. Thank you and have a great day.